In order to start with a better understanding of traumatic experiences, I thought I would share the models with you. I'm not talking about the background, just allow me to talk about the models, because that is really important if we talk about the background and the numbers and what to look out for. So there are mainly three models of a traumatic experience, which are also influencing all the stats and the epidemiology. One is the concept of life events, which is just very descriptive. It counts and it is acknowledging all the different problems and events somebody has gone through or is going through. That was a very important concept informing also the onset of severe persistent mental disorders. The second one is a concept which is quite well known, that is about adverse childhood event. It was kind of, or is also mainly descriptive, but it is providing different categories. It has this going through 9 domains and general categories, and is very helpful in predicting the potential negative outcomes, the onset of intravenous drug use, for instance, but also all kinds of other things you want to look into. It's a very helpful concept. And then there is a third concept called, is based on this childhood trauma questionnaire, which is a model-based concept, a conceptual concept, which is based on 5 categories, for instance, emotional neglect, sexual violence, physical violence, and other things. And it has a very good predictive value about the impact of traumatic experience on later on mental health issues. Just to look at that one, this is kind of based on life events. The stats I showed also in the keynote. So these kids were asked before they were asked about events before they became addicts or started to inject drugs, and it was compared to a representative sample of youth. So I found that pretty mind-blowing, that nearly half of them experienced a separation or divorce, or 1/3 developed the death of one of the parents, or a severe own illness. The mentioning of suicide is critical, because probably the more among people injecting drugs, more than half, so about 54%, are committing suicide attempts in their career. So that means all of them are close to 3 times as often as a representative youth number. So we know about the risk, and we know what happens far earlier than the event is happening. And this is what I'm saying. We need to respond to these early warning signs. We need to identify the most vulnerable in order to focus on our attempts of supporting that very much on the most vulnerable. So I really recommend to have a look at that ACE instrument, because it's easy to use, and it's a very helpful tool in order to identify the amount of trauma and the urgency of interventions. And last but not least, the CTQ, as mentioned, is based on the assessment of physical abuse. It's a self-rating and a standardized instrument, emotional abuse, neglect, and sexual abuse, and it is leading to an overall categorization in three clusters of trauma. Okay. Last not least, also as an important category, I just wanted to mention the transgenerational aspect of it, which is described well, which is also happening, or in Canada and North America. We are especially studying based on the negative experience in residential schools and in the process of colonization of North America. But actually, the concept of transgeneration trauma was first developed for individuals or families of Holocaust survivors. And all the terminology was kind of created in the work of with Holocaust survivors, trying to understand the psychological impact of disastrous trauma and experience to the next generation. So that is something to keep in mind and to learn from.
Hi, Mike. Sorry to interrupt. We have a question. Would you like questions now or at the end of the presentation?
Yeah, let's have questions right now.
Great. So we have a question that says, I find the separation and divorce interesting and somewhat contentious, as we know that half of marriages end in divorce. So does that not complicate the outcomes, and the way that parents deal with divorce is more than the actual divorce itself?
I think the question is there, how do you describe it? But actually, the fact is it's not about divorce, it's more about separation. So that the children are in the situation, and probably in the 90s also the situation was slightly different to today, where close to 50% are getting separated or divorced. But in any case, a separation of parents and fights in the family and whatever have a significant impact on the next generation, on kids. And this is an impact you need to deal with. It's not judging, that's probably it became a fact of life, but the instability of the family environment certainly makes it more complicated for kids, especially in their complicated phases of life, like the transition from adolescence to adulthood.
Thank you. And a follow-up question by the same person asks, yes, so would it not be better to say that conflict in families is more impactful?
Yes, but that's a fair description. But also separation is a description. I don't think to saying, for instance, certain events have a critical impact on development, which you need to deal with, is not stigmatizing. I think it's important as part of the therapeutic and the clinical response, as well as on the, let's say, scientific or model discussion, to be able to gain a clear understanding what we're talking about. And separation is a critical thing, and violence is a critical thing, or tensions in a social network or in a family are important. So it's more the consequence which is important. So you need to find a way to help adolescents or kids to deal with it, especially if they're very young. So one terminology I really find helpful is this term, which is also coming from the work with Holocaust survivors, is called the conspiracy of silence. And it's a description of a common behavior in families of Holocaust survivors, but it's also true in our tendency to ignore traumatic experience, like it described in a handbook of Transgeneration Trauma. The victimized parents during the Holocaust didn't really have the ability to speak about their experience, which made it extremely complicated for the following generation to recover from that too. So the conspiracy of trauma is kind of happening also in the system. If you really consider very often people and coming to emergency rooms and looking for help for whatever reason, for different reasons, suicide attempts or overdose or whatever. And actually, there are a few things they very regularly or nearly never are asked for and assessed for. One is traumatic experience, especially childhood treatment or sexual violence. Second, very often the assessment of substance use and high-risk substance use is very rare and is not happening in an appropriate way. And then also the circumstances in life are very often stay in the dark, like living in marginalized housing or being homeless, being unemployed or things like that. So there, we have a conspiracy of silence, not only in the families, we have them, the conspiracy of silence also in our system of care and in society. Okay, I stop here in order to give more room for interaction.
We have one more question in the chat, and this person says that they are curious about the wish to die that you mentioned earlier in the presentation. What are the upstream precipitating events that contribute to the downstream wish or suicidal ideation?
What you saw from that stat is so this extremely high number for later on heroin addicts, when 58% having the wish to die. And we have not much additional information about what exactly they were thinking and saying. And you see the same thing in a representative sample of youth, which is also not small, 15% of average, normal, more or less healthy youth or not diagnosed for any condition says they had the wish to die. It is something which is coming up like a depressive symptom or mood symptom in their developmental state. And the later on, or the heroin addicts have the experience of committing a suicide attempt in around 54 to 55%. So that tells you that there is, if you're not intervening, if you're not doing something to help them to cope with certain adversities, at some point they will try to take their own lives. And at some point they also succeed with that. And we know, for instance, that a percentage, at least from the research earlier done on overdose, that a percentage of about 15 to 20% of the overdose events were suicidal in nature. So, so that is, so what I find important in that result is that you learn things earlier. You learn them kind of very early. You could know very early, and you need to address that and deal with that as early as possible in order to stop people being self-harming, going high risk, and become suicidal. If you again also think that so the suicide is only one aspect of that, could be also leading to self-harm. A lot of these adolescents are cutting themselves, or they accept a higher risk because of an ambivalence. Is it really worth surviving or not? They don't want to kill themselves, but they don't care about themselves. So that is the purpose, or the background we were interested in that specific topic. Any other responses? I think it would be also great to hear about the experiences of, uh, uh, of our workshop participants more. Yeah, my question is there, for instance, would be, but I invite you to also to pose question, but what I would find interesting, are there, let's say, attempts to integrate trauma care and substance use care in your part of the world? Is trauma addressed as part of substance use care, as part of substitution, as part of withdrawal management and stuff like that?
So I'll make a quick stab at it in a very general way. I'm in the Northwest Territories, and as a result, we only have a population of 44,000 people, but we have 23 communities and I can't tell you how many million acres, but we are in the process of changing a lot of how we do the work that we do, so that trauma is a very informed practice that's a part of the conversation. Mm-hmm. So we are doing one at a time counseling kind of things, or one-stop shopping, which is almost like saying a client comes to the door and we make sure that we're able to see them and do something with them. So trauma is a part of the conversation. And so that fortunately for us, with the population that we have, we're able to say we have people who are generalists who wear many hats. And as a result, it's much easier to have the right door for people to show up at. And but part of the challenge is that living where we live, many times we have to transport people to receive specialized care. But even the beginning of what that care looks like is critical to building the relationship, to wanting them to go to other communities and other locations to receive other care. So it's for us, it's a very complex problem because, the reality is that a Zoom type call doesn't really answer the question for many people. So it's a very complex question, but trauma being a part of the conversation and overcoming the stigma piece about what trauma is about and where it fits is a large part of what we do and how we address things.
How could that be supported from, and for instance, would say from your experience, let's say an online conversation or a trauma structured trauma treatment programs or whatever, would they be a helpful asset for you, or what would you as a professional there, an experienced professional, what would be the best possible support?
I'm at the same time, I'm trying to couch this with practical answers as well, because ultimately we would love to have the access to professionals who are able to deal with these kinds of things. So at the moment, I would suggest that having this type of an environment with a very solid internet base, so that we're able to at least have those things available to people. Because at the moment, those are things that don't exist in a practical way. Yeah. So as a result, I end up wearing way too many hats, and it becomes problematic.
You mean that, so you're saying the integration into addiction care would be overwhelming, or would be?
It would be appreciated. It would not be overwhelming. The response that we get at the moment and the response that we have received has been very positive towards people accessing us through through this mode of communication. It has been a big boon to the work that we do sometimes. Of course, there are resistant pieces to it, such as not having the ability to be able to communicate effectively, but not having the right equipment.
Yeah.
But generally speaking, this is young people happen to love the medium, and as a result, they're able to do some of the things that are there if they have access to it. Now, what that means is that we have to expand how we understand and what we do and how we connect with them.
I'd like to just say that the previous chat by Chantel Burke, I really agree with. And I do feel that trauma-informed practice or care happens if people have been trained to engage in that way, or are trained to recognize trauma or understand how trauma manifests itself in people's behaviors. And so I think that at times people aren't as well trained in understanding trauma.
I agree fully with you, Cynthia, that a good training and as well as a good supervision. So if you are working a lot with a highly traumatized individuals or complex history, then it's important to get support in dealing with that. Like a lot of people in the healthcare system are saying, we see a lot of burnout. We see a lot of direct breakdowns, also among the healthcare professionals or the professionals in the housing and other systems. So training and supervision are certainly critical. But Cynthia, what are you doing then with your clients? Is there a kind of, do they have an opportunity to meet a professional in that area, or is it kind of integrated into the services there?
Well, I work with the Addiction Medicine Consult Service in a hospital on Vancouver Island. I think that in the community, certainly there are very trained people that do have the ability to support, understand, recognize trauma, develop sort of a care approach to, with that trauma. In the hospital, I think in terms of, staff that young people would encounter if they're coming to the emergency department, I'm not so sure that, people are as trained or in fact, deal with or set up care from a trauma-informed lens. That's just my opinion. And I agree with you. I think that, supervision really is key. We attend, these workshops and in services, and we learn and we understand and we try and implement. But often there isn't the support or that supervision to say, hey, maybe let's look at doing this a bit differently. And I do think with adolescents, acting out adolescence, oppositional defiant disorders, all those kinds of things are really difficult for people to deal with. And I think that puts people off. And so never mind if, somebody is traumatized and acting that way, it's just a really challenging behavior to deal with.
Yeah, and you need to be prepared to respond to that, and you need to know what it means when they be acting out, and if they become nasty, or if certain behaviors are coming up because the experience they had were probably as nasty as that. But are there other among the, let's say, participants? Are there other examples?
I just wanted to follow off of what that last person was just talking about and what some people are talking about in the chat here, and like the importance of the supervision, and you're talking about burnout in healthcare. And I think a lot of people in this this group can probably attest to that. I know for myself, working with youth and in addictions, and I'm wondering what that looks like when we're saying, you know, good supervision and support. Like, what can that look like for the clinicians that are working with these vulnerable youths? And like we saw in the other presentation, you know, witnessing overdoses and deaths. Just from your perspective, what do us healthcare providers and people working with these youth, what do we need, or what do we say is good supervision or support?
I think there are some basic things, starting with the professional training you're going through. I think to have a good understanding what's going on, have a good understanding about the history and how to structure a history and what to focus on. But if you talk about let's say, the daily work of healthcare or housing professionals, and I think very important is to have access to kind of, let's call it sounding board. So that could be a group, that could be understanding senior colleague, and that could be a specialist. So at different levels. I think if there is a complex critical situation, it should be always possible to let's say, have a common round together with an expert looking from outside, because supervision, from my perspective, also to a large degree needs to be kind of independent in terms of looking from out of the system and being able then to help to moderate also the relationship between the professionals and the users and also their networks. So ideally, I think there should be a regular group setting discussing cases that should be moderated and led by more experienced colleague. Nowadays, I also think you could have regular webinars like that, hiring, let's say, an external social worker or psychologist or counselor who would help you with sorting that out. I find it really important to use all the tools you're recommending to your clients for yourself too. So actually, I think to document your experience on a regular basis, you need to also be able to learn, actually, what's happening now is beyond normal. So I'm suffering myself, and I need help probably also myself. Look, I'm talking about my professional group, the physicians are the worst getting help. Absolutely, they're totally ignorant in regard to their own health, right? Suicide rates among physicians is higher than average population. Depression rate, they and nurses also very often, they're using more psychopharmaca than the average population. And they are very reluctant actually to talk about themselves, and that something is beyond their own capacity, which is, I think, is normal. There are often things happening beyond my capacity. So, and I then try to use my personal network, but also talk to somebody who's independent in the professional world. And that is, I think we need to accept that as normal. That is not a failure. I think that is, from my perspective, that is an indicator for strength, for reflection, and for an appropriate seriousness.
Yes, thank you. Thank you for speaking to that.
Thank you for bringing it up. It's so critical. Are there, I want to encourage you, are there other groups or programs which have a good integration of trauma care, or having access to trauma care or good mental health care is part of their work with adolescents.
So something I just wanted to quickly touch on, I was noticing in the comments section or in the chat recently, was from Jen Lee, it looks like, just regarding like trauma-informed practice versus trauma-specific therapies. And I think where I work in interior health here in British Columbia, it's like a mandatory required education for staff here is trauma-informed practice. But this idea of dichotomizing trauma-informed versus trauma therapy, and what I often see is sort of people fearful to work with people with trauma. Like, we're good at identifying a trauma and what that looks like and the behaviors that kind of go with that, but not necessarily addressing and creating safety for those folks in our environments. I think a lot of times the language I hear used is around things like managing behaviors or limiting service if there's sort of like people with severe trauma experiences that are accessing services like in the traditional routes. And so I don't know if we're the best at sort of integrating sort of trauma type safety mechanisms within our practices. I think we're getting there. I think we're getting better at having those conversations, but I don't know if we're quite there.
Yeah, thank you. I think it's kind of also high risk to work with this dichotomy, because actually, first of all, our patients are not dichotomizing their needs. They're coming with their lived experience, and they want understanding. They want help. They want somebody to be available for them. And if you talk about these kind of poles of the trauma-informed care on the one hand and treatment on the other hand, I think treatment already starts if you are able to listen to the stories, if you're able to structure what's happening and be kind of reaffirming, what happened there and what you are feeling is quite impressive, and that is part of the problem. And yeah, let's find out what we can do together. I think a big part of the work with traumatic experience or life events is to be empathic and to be accepting. And so to be informed about what's possible, what trauma means, and what the treatment options are, that's a good start. But also to get kind of a toolbox for yourself, what the options could be, and how to assess what's going on, how to structurally and how to describe that is a second relatively easy step. So that's the reason I mentioned those three models of traumatic experience. If you are able to get a better grip on that, then you get a good or better understanding when individuals need more than just being there and being receptive and empathic, and what that could be. So, but it's a starting point, but it shouldn't be an excuse to do more. That's my 5 cents to that one.
And can I ask a question?
Please.
Megan Cunningham here. Yeah, so do you think it's partly the, sort of reticence for people to explore trauma or even just ask the question of like getting curious about that is some of the roots of, like, I don't know if it was in the 80s or 90s where it was all the flooding and people really, it wasn't sort of therapy that was necessarily helpful. Do you think that is what sort of continues maybe why so many people are just even afraid to ask? Like, I mean, I work in mental health and substance use and mainly acute psychiatry. And it's shocking that, how little we ever go there. You know, there's an assessment and sometimes it won't even be broached about the trauma history that we know, we absolutely know that it's there, right?
Yeah. I find it so. So first of all, I think one of the first steps in dealing with this situation is to develop your own model and understanding of traumatic experience. And I see traumatic experience as the fathers and mothers of psychotherapy see it as a catalyst. So it is severe traumatic experience is leading to a lot of the dysfunctional response in terms of depression or psychosis or whatever. It's contributing to a lot of serious negative and threatening developments. And I think it is. I think it's the not asking is. I think a way of trying to avoid what's happening to let's say or feeling the inability to respond appropriately. But that is the most important catalyst for mental challenges. And if we are not addressing that, we are kind of missing the boat, and we are missing why there is a mental health care system. We need to include the understanding of traumatic experience as the consequences of high-risk substance use or the suicidal ideation, suicidal attempts, in order to be able to respond on the right level. That doesn't mean everybody needs to go into treatment, but if needed, you can effectively address the trauma-related psychopathology. Nobody needs needs to suffer lifelong on nightmares or on chronic anxiety or on other PTSD symptoms of that kind. That would be my view, my worldview. I want to encourage you. I think it's not a burden. It becomes much easier. The more you understand, the more you are able to respond and to deal with these challenges yourself. And also, if you understand this traumatic experience is also somebody, every health professionals in mental health or in healthcare in general is experiencing, then you probably also learn to deal with it better yourself in regards to your own needs.
I have some comments to make, if that's okay.
Yeah, sure.
My name is Jas Sandhu. I work as a substance use counselor in White Rock, South Surrey. When I hear a lot of the discourse on trauma, there's a real doom and gloom. A doom and gloom. And I find that very unfortunate. With a lot of the trauma research that's done, I notice there's a lack of a sample of folks who've been resilient in their trauma. Partially because those who are resilient and integrated into a regular, what we call normal lifestyle, what that is, we can't catch them. They're enjoying life. They're enjoying life. We're not catching them. And that's unfortunate. So in my work, I take the perspective of using positive psychology. We talk a lot about training and competency. I remember one of my First Nations clients said to me, "Jas, do you need training to be nice?" That was his comment. Do you need training to be a nice person?
Probably.
Very simple, very simple.
Mm-hmm.
And what I find that's been helpful for me in my journey and with my clients is using mindfulness-based practices. Mindfulness is a way to help our clients to sit with their suffering so they could build a containing wall. So when those emotions or thoughts do bubble up, they're better able to sit with those feelings. And I think a lot of clinicians, from my experience, get caught up into the day-to-day drama and stresses that are occurring in our client's life. And we don't take a moment to really pause to sit with our clients in those moments of uneasiness, to really feel that together. And I think it's very important for us in our own personal practice to know what it feels like to sit with our own suffering. Only then can we sit with our clients and sit with their suffering, as opposed to just throwing strategies and recommendations and the whole crisis management. So the analogy I use that is of in the game of life, let's press pause. Let's take a time out. Just pressing pause. And from there, maybe with some calmness and peace, we could create a new game plan, and really looking deeper within the individual, not just looking at the wounded aspect of our client, but that resilience within them. And I think we have to tap into our own resilience as people to be connected to that, so we could help our clients connect with that as well. Because I don't know how people are doing their work in other areas, but I've had clients come here, youth, and say to me, I did this ACE survey at school, and the teacher said, if you have this score, this score, this score, you're going to have this, you're going to have this, you're going to have this. That's further traumatizing our young people, and they go out the door without any resources or any support, feeling more, that shame, that things are hopeless for them. And well, this is the future for me. And have I heard clients say that? Well, this is the story of my life and the story of my family's life. So I'm just following in the family tradition. So I think it's very important for us to really sit with those moments where we can create peace, tranquility, serenity. And we can only have that if we cultivate that in our own personal practice as well. So we could sit with that, the suffering, and to facilitate the process of resilience to unfold within our clients. So I just want to share that with everyone. Thank you.
Thank you. Thank you. I totally support the notion of resilience, and you mentioned how important it is to try to build on strength and not just on symptoms. And sorry if I focus too much on that. Probably my motivation was to raise awareness. And what you're saying is to build a resilient or to support the building of resilience, to build on your strengths as part of dealing with traumatizing experience. That is correct, and I agree with that. And mindfulness is one strategy to do that, and there are others. And there is a range of needs of traumatized individuals, which you need to address with a range of tools. And this is what you're learning through your professional career. And you are probably professionally able to work in that area also with the lived experience you mentioned, with which a lot of health professionals have, if you are resilient to a certain degree. Also, resilience is not something which is kind of a static thing you always have. That's something you need to nourish. That needs something you need to feed. And for instance, a strong relationship or a strong family or empathic friends or success or other things are actually building your resilience. And our clients very often don't have that. Yes, you can't avoid negative experience. And one of the major strategies is to approach it from a strength-based angle, the amount of resources you have is more important for your recovery than, or you can mobilize, than the challenges or the amount of problems you're having. So, and if you read the chat, yes, there are a lot of thank yous for you from different angles of Canada.
You know what? I'll just speak to this really quickly. Thank you, Jess, for sharing that information. It was really helpful to a lot of people, it looks like. I said earlier in the chat about the importance of how we're framing questions as well, which I didn't necessarily mean in specialized services as well, but even in primary care settings. I gave the example of asking somebody about their suicidality. So kind of going through, and Jas, what you were saying is bringing in mindfulness to that as a clinician or as a healthcare worker, which I think is very important because we get so caught up in following these forms and standardized questions that we don't always put a lot of that empathy and understanding into our questions. So one thing I found out recently about myself is when I was asking about suicide, do you have thoughts about suicide? Do you have thoughts that life isn't worth living? And the kids that I work with who are just as involved being like, nope, once in a while, but not really. And I recently heard changing that question to, well, how many days do you have the thoughts that the world would be better off without you? Which then most kids say, well, probably every day I have that thought. So I think about all the times I might have missed the trying to figure out, well, yes, I assume in my line of work that everybody has trauma, but not everybody is affected the same way as by trauma, like you were saying, for resiliency. So how are people affected by trauma? And if we're answering, if somebody's having a thought they don't want to live every day, that might be really driving that substance use. And so how do we then find out how it's affecting them? And are we missing the opportunity to actually refer to specialized services because we're not taking a second look at, well, how did we ask this question? So I've thought myself, how many youth have I missed to refer to something more specialized because I've just taken them at their word and thought, oh, they're not as acute as maybe one of my other clients. So I just wanted to talk about that a little bit. And Jas, you saying to remember to be mindful is just a really good reminder to think about that and think about how we're asking our questions.
Yes, Tara, I think that's a good thought. The problem may become if you make it really, if the barrier is too high to ask and you are too cautious, that you may do something which is also, I think, not respectful, not asking at all. These all you mentioned that these are thoughts which are important for our clients in any case. And if they never have the opportunity to comment on that, to talk about that, that might make it even more complicated. But it could go in both directions. So we could be mindful, we could be supportive, talking about strengths and about how good coping strategies could look like, but also being aware of that they are carrying something which we should help them to carry and should help them to address.
Let's just kind of provide a quick comment about mindfulness, about thoughts and emotions and trauma work. There's a lot of discussion about frontal cortex. So mindfulness is a good technique to help strengthen the frontal cortex so our clients aren't flooded when they do talk about it. So imagine if we're digging a trench. When we dig a trench, we have to put in a retaining wall. Once the retaining wall in, then we could go in. So in order for our clients who have traumatic backgrounds to talk about the trauma, it's important for us to build that containing wall, the retaining wall, so they don't get caved in the process. If we go in too early with the trauma dialogue, they could become flooded. I've seen this where new clinicians or maybe persons who aren't trained in trauma-informed therapy, they go in too quickly thinking they are trauma-informed because they want to talk about the trauma. But that can lead to the client becoming triggered, and literally they'll go outside the door, down the street, and be so triggered that they're using, or they'll go in the washroom and use. So it's important for us to build their capacity to deal with that inner agitation, the physical, emotional, mental consequences of the trauma, and then very gently and with kindness allow them to slowly allow the trauma, those experiences to emerge and to be able to discuss without being flooded. So when I'm talking about mindfulness, what I'm not saying, oh, it's just a thought, let it float by. That's not what we're saying here. What we're saying here is we're getting used to the feeling of the traumatic experience, the impact of it physically, emotionally, mentally, as it comes up, and allowing the mindfulness practices to strengthen the frontal cortex so we don't get flooded, so we're able to deal with those uneasiness of the trauma and talk about it. Or else a lot of my clients will say, the switch goes off, I feel agitated, I feel uneasy, now I have to go and use. So I don't want to give the impression that I'm coming from orientation that a thought is just a thought and we could just put it to the side and it's fictional at that point, right? So it's being able to deal with that inner agitation, the uneasiness, so that we can talk about the trauma without being triggered. If we go in too early, it can lead to more problems. And I've seen this with clinicians who aren't trauma informed, they want to go in deep. And sometimes I get clients, they'll say, I want to get to the root of the problem. I want to go in deep. And the first question I ask them, are you ready to go there? Do you have the skills to go there yet? So we have to create a safety plan and develop those skills so we could go in. Right? It's not like television where the person on the sofa, they start doing their psychiatry or psychoanalysis, Freudian style. And with our clients, it's very risky when we go to those places. So that's where I was coming from in terms of mindfulness-based practices.
That's true. And let me, in the end, try to bring together also the substance use and the trauma piece in a more, let's say, simple picture. Very often, psychotropic substances are the only way for some of our clients, or most of our clients, to kind of deal with the pain, the psychological pain and emotional pain. And I call that self-medication. And in order to help them to move to other and better and more effective coping styles and developmental strategies, building on strengths and building resilience is the best possible answer. And if we start as professionals think the same way and also ask for support for our resilience, I think we are really good equipped, even if we didn't have a psychotherapy training.
Mm-hmm. The one of the key concepts I like to articulate to a lot of my clients is that of skills and pills. That the medical model, they'll help you with the pills, and the counseling is about the skills, and we could use them together like a bird. A bird has two wings.
Mm-hmm.
You need two wings to fly. So with a lot of my clients, I'll give an analogy of the two wings, that of being skills and pills, how they could be used together. And the research just show when we use those two approaches together, they work. Now, when they're going onto the street for their pills, we have to have some discussion about that as well. But I just think it's very important for us to really create those spaces where our clients aren't being re-traumatized by just the doom and gloom of their situation.